Our first presenter will be Professor Sonak Pastakia. Assistant Professor of Pharmacy Practice, who will be Skyping in from Western Kenya through the miracle of modern technology. He will describe his project BIGPIC. Now BIGPIC is interesting. I thought it stood for Big Picture, but it stands for Bridging Income Generation with Provision of Incentives for Care, and you'll understand the acronym when you hear his presentation. He's using a combination of group motivations and incentives to not only encourage diabetes patients to improve their own health through self-drug management, but also the health of other members of their community through peer drug maintenance. And the results he's achieved in reducing blood sugar levels in just 1 year is remarkable, as you will learn. So with that, we'll try and bring up Professor Sonak Pastakia from Kenya, and we'll hear his first presentation, which will be, again, Bridging Income Generation with Provision of Incentives for Care.
So thank you all for coming to this presentation. I'm sorry I can't be there with you, but we've sent some of our Kenyan residents, and also Ellen and Monica are there, so you can definitely ask them all the questions that you might have about the program. And especially the Kenyan residents, because they've lived through with the system their whole life and have greater insight on it than I ever could. But to start this presentation, I just wanted some of the diabetes, which indicate that it kills 1 person every 8 seconds and 4 million people a year. And despite a lot of the common misconceptions, diabetes does not discriminate. All ages, rich and poor, and all countries are affected by diabetes. And one of the reasons that I really mention that is because whenever we have guests who travel to Kenya and come to our diabetes program, one of the first things they always mention is that they're surprised at how much diabetes there is here. And I can definitely tell you that there is a large and growing burden of diabetes that we need to address now before we have an epidemic similar to what you see in America. Next. And so my name is Dr. Sonak Pastakia. I'm an assistant professor with Purdue, and I serve in a very unique capacity in that for the past 5 years, I've been stationed in Kenya full-time and spend anywhere between 10 to 11 months a year there. And today I want to talk about the GPRI-sponsored project, which is called BIGPIC, which stands for Bridging Income Generation through the Provision of Incentives for Care. And I want to basically outline some of the basic aspects of this program, and I wanted to even change tack from what I've done in other presentations, where I want to give you a bit of the policy dimensions and some of the underlying aspects of that really limit care in developing countries. And so it'll be a little different than what I presented in the past. And I also wanted to give you an update on some of the early findings we have from BIGPIC since we've started it in the past month and a half. Next. And for this next slide, I basically wanted to use this slide to set up a background for what I basically see as the challenge of development. If you look on the left side of the slide, basically you can see that in a market-based system, we're able to basically do anything. In July of 2005, we were able to distribute 9 million copies of Harry Potter in a single day. And a lot of these findings come from a professor at New York University called Bill Easterly. And so we were able to distribute 9 million copies of a single book in a single day and essentially address all the demands for this book in a single day, which to me is pretty amazing. And then you also look at a company like Coca-Cola, where even when you go into the remote hills of Kenya, you'll still see a big Coca-Cola sign, and you'll still be able to get a bottle of Coca-Cola. But then if you look on the development side and some of the challenges with that, despite over $2.6 trillion of foreign aid in the past 5 decades, we have not been able to effectively distribute bed nets and anti-malarials to the patients who are literally dying of them in front of our face. But yet at the same time, we're able to get Harry Potter to every man, woman, and child in the world who wants it on the first day of its release. 1 billion adults still remain illiterate, and stockouts are the norm in the most public healthcare facilities. And you can see here just how perverse this dynamic is, where these market-based goods have basically reached every aspect of society, whereas these things that are almost considered essentials for life have not reached the patients who need them most. Next. And so now I take this slide and this concept from one of my favorite lecturers during public health school, Jim Kim, who's now the World Bank president. It was one of the lectures that definitely stuck with me as I joined the AMPATH program in Kenya. And so one of the big things that he talks about is this whole implementation bottleneck. And so you have this very simple bottle here, and you have all these ideas, all these things that we want to do, but all the developments and the positive aspects that we want just basically trickle out. And I wanted to talk briefly about why this is. Next. For this picture, I wanted to basically illustrate some of the barriers here. And so AMPATH is a collaboration between Moi Teaching and Referral Hospital, the Kenyan Ministry of Health, and Moi University. And we've all acknowledged, anybody in the development community would readily acknowledge that diabetes, maternal and child health are very important issues that need to be addressed. And so we got funding from USAID to do this, but it took us over 2 years to get a document signed to just actually address, that actually described what we were trying to do and gave us the freedom to actually do it. And so this is definitely a huge challenge for us in that it took 2 years, despite the fact that we had money, to even get this thing. And so the bureaucracy in any system is one of the huge bottlenecks. And don't take my message the wrong way. The same kind of bureaucracies exist in America, where if you look at Obamacare or even Hillary Clinton's old plan for healthcare, we still don't have a healthcare plan in America that's really addresses the needs of the poor and the rich. And so these bureaucracies are everywhere, but it's especially pronounced in developing countries and is one of the main rate-limiting steps. And if you look at the bottom left corner of the slide, you see a hand. And what I use this to represent is the invisible hand of the market that all of us learned in our basic economics class. That's, the theories of Adam Smith, where there's an invisible hand of the market that kind of controls things. And so this works great for America and a lot of other capitalistic countries. But what you realize that happens next in developing countries is that you have basically through the input of foreign aid, this invisible hand of the market is basically gone. And so you don't have the typical market-based controls like you would with Harry Potter, where there's 9 million customers who want the book and 9 million customers who we have to make sure get it. When you introduce free goods, a lot of these invisible market forces that really ensure that people get access to commodities basically disappear. And so this, to me, is one of the other major bottlenecks that you don't hear people talk about too much, but to me is one of the main reasons why development hasn't had the effects that we expected to. And if you look at the top right, one of the things you see here is in the top right, you can see the maternal mortality rates for America and Kenya. And so in Kenya, the mortality rate is 590 per 100,000 births. And in America, it's 8 per 100,000. Despite the fact that we've had all this aid and all these other factors. And to me, those are just unacceptable things. And these are, to me, consequences of some of these bottlenecks. And the picture right next to that which shows a bed net, the reason I show this picture is when you take out market commodities, you'll see some perverse kind of examples. And so what happened with bed nets is a lot of companies decided, because of the huge need and a lot of these efforts by Bono and a lot of these very famous celebrities who go out and say, bed nets need to be free everywhere. What actually happened was when you give these bed nets away for free, the recipients don't actually value them. And so if you go into a lot of households during home visits in Kenya, what you actually see is bed nets being used as couch covers, as curtains for the door, and not really being used for their intended purpose. And this is largely, to me, because you've taken out the value of this market-based good. And so now these are just some basic examples, but next I wanted to focus on some of the examples that are directly applicable to what we're doing with BIGPIC. And so here you can see insulin and glucose testing supplies. I can tell you that before we started doing a lot of our work almost 5 years ago, the vast majority of patients had no access to insulin. And the reason for this was that it was a solely private market commodity, where there's a large enough rich population that can afford a high-priced insulin that these companies felt very comfortable keeping the price very high. And so for poor patients who had diabetes, it was essentially a death sentence. And I can tell you that the vast majority of patients died before we had an insulin donation program. And so that's one example. And then if you could go next. I don't like just talking about the negative examples. One of the things that has actually slipped out is microfinancing. And so microfinancing is one of those things that really starts to address what Adam Smith talked about with the market.
And what microfinancing does is it actually gives poor markets and poor people credit so they can actually buy things. And so one of the thoughts that we had was, okay, so here you have insulin that's very expensive, you have diabetes supplies that are very expensive, and you have microfinancing, which basically gives economic power and credit to patients who are poor. What happens if you combine the two and create a comprehensive healthcare program that takes both business principles and economic principles and then also healthcare principles and mixes them together? And what we get is the whole concept for BIGPIC. And I'll talk a little bit more in detail about what BIGPIC is and what it is, but I really want to set the stage for all the factors that surround BIGPIC so that you can understand why it works and how it works. Next. And so in this chart, I wanted to also describe one of the big changes that I think is happening, and I'm actually hopeful that it's happening. And from talking to a lot of my business colleagues in pharmaceutical industry, it's clear that it's starting to happen. And so in this slide, you can basically see, if you look at the left column of that table, you can see the population in millions and the annual per capita income. And so there's, if you look over to the left, 75 to 100 million people who make over $20,000 a year. And then in the middle income, you can see the numbers there. And then in the bottom part, you see over 4 billion people who make less than $1,500 a year. And so you can see the perverse dynamic where most people throughout the history of business have focused on that high income bracket there. And you can see even the slide that it's barely even visible, where it's such a small portion of this actual pyramid of population that is barely even visible. Whereas the middle income and the low income, for the most part, have been priced out of most healthcare markets. And one of the big things that we're trying and we're suggesting is that if you actually think about the economics and the calculations behind it, this low income group is such a large part of the population that even if you lower the profit margins that you get from them, because of the volume, you'll still make a pretty nice profit. And if you don't address this population, you're basically foregoing a profit from such a sizable proportion of your population. And so this is one of the other big concepts that's starting to really take hold. And this is one of the things that I've been preaching ever since arriving in Kenya, where I think a lot of the traditional strategies for development are not really the right way to go. I think the biggest sign of respect that you can show people is that you start to treat them with the respect that you would treat a market that you're serving. And so as we start to change towards this more evolutionary, this more robust and comprehensive approach to populations, I think you'll start to see businesses and corporations come in and start to address a lot of the problems that we see in the low-income sectors of the developing world. Next. And so now I wanted to transition more to give you some background on AMPATH. And I know I've probably given this before, so I want to cover this fairly quickly, just so if there's any new people in the audience, they know exactly what we're talking about. And so just to give you some context for AMPATH, it's basically a consortium between Moi University, Moi Teaching and Referral, and Indiana University School of Medicine. They've come together and created this IU Kenya partnership. And then IU School of Medicine basically coordinates all of the different institutions like Purdue that come together and come on the ground in Kenya to develop this robust partnership called the USAID AMPATH partnership. And this program used to stand for the Academic Model for the Prevention and Treatment of HIV/AIDS. Next. And the name has now changed to the Academic Model Providing Access to Healthcare. And this is largely because of the work of individuals at Purdue, the work of people at Brown University, and all these other universities that have been pushing this chronic disease and primary healthcare agenda. We're basically all agreeing that doing HIV care is not enough to just address a disease that affects such a relatively small portion of the population while letting all of these other diseases basically decimate the Kenyan population is simply not acceptable. And so USAID AMPATH is basically setting a whole new trend and a whole new pathway for actually addressing the wide range of diseases that patients in these settings experience. And so this is where we're at now, and we're now the academic model providing access to healthcare. And so AMPATH was initiated in 2001. You can see the map with all the care sites we have throughout Western Kenya, over 65 of them, and we serve a catchment population throughout that area of almost 2.9 million people. Our HIV prevalence ranges anywhere from 2 to 30%, and we have greater than 150,000 ever enrolled HIV-infected patients with over 58,000 on antiretroviral therapy. And so we are one of the largest programs in all of sub-Saharan Africa, and for the past 2 or 3 years, we've really been starting to get a foothold in starting to address a lot of these other disease states. Next. And I wanted to give you a sense of the comprehensive nature of what AMPATH is doing and what this whole transition of AMPATH's name from just HIV to everything. And so one of the things that you realize very quickly when you start delivering care in a resource-constrained setting is that if you don't address the whole picture of that patient, you're basically doing them an injustice. If you treat HIV patients with drugs but don't provide food support, you're going to diminish your outcomes. And so AMPATH has brought all these different departments together to create this comprehensive AMPATH program. And what happens with that is if you develop a comprehensive program for HIV, you can start to address all the other disease states. And you can see the long list that we now have care programs for to the left that we now serve by layering a lot of the infrastructure that's needed to manage those diseases onto the infrastructure that's been created by AMPATH for HIV. And we've done this with great success. I can also tell you that USAID is very interested in replicating this approach throughout sub-Saharan Africa and other areas where they've given HIV support. Next. Now I wanted to give you some context for what we actually see on the ground with diabetes. And so I can tell you almost at every clinic I go to, there's at least one new patient who comes in and is newly enrolled into diabetes care. And so you see this kid, they're doing great. Their diabetes has not really had the complications that we typically expect over time. So they have some of the underlying symptoms. But now, as I mentioned before, if they don't have access to insulin, what we always see is they end up going down this path towards all the complications of diabetes and then eventually death. Next. Okay, so then we have this partnership with Lilly. So now we have access to insulin. Next. After that, the next thing that these diabetic patients need is they need access to supplies. So things like glucose strips, A1C testing, and all of these. And without that, you can't really monitor the insulin appropriately, and they go down that same pathway. At around 2 or 3 years later, they start to have all the complications and eventually die. So then what we did is we struck up a partnership with Abbott, and now we've partially addressed some of the supply needs for diabetes. Next. And so the next thing you see is that patients also are very food insecure. And I've talked about some of the data from that before. And this is actually a paper that we're about to publish in the next 2 months that show that around 30% of the diabetes population in these rural populations have food insecurity. And so that's a big determinant of poor diabetes outcomes. One of the other things is that very few patients have the money for transport or even the time to get all the way to one of our few clinics. And so these are the main barriers that patients suffer from. And once again, what we've designed with BIGPIC is that if you address these barriers and make patients economically sustainable and stable, they can address these issues on their own. And so this is one of the other big determinants of BIGPIC that we're hoping to address. Next. And so one of the big unique things that AMPATH has just started in the past year is this whole model called FLITR, which stands for Find, Link, Treat, and Retain. So the first step, of course, is finding. And so next, you can see here we are one of the pioneers in home-based counseling and testing. So what we started was HIV testing via the home. And now we've added on blood pressure screening in small portions and diabetes screening in small portions. And the big challenge with that is that you can find all these patients, but the next step is linking them. And so once you link these patients, one of the biggest challenges is getting them into the care system. And so what we've developed are mobile technologies through Android phones and network connectivity that allow us to basically register a patient at their homestead and transport all that information via cell phone technology to our main database server. Next. After that, of course, you want to treat those patients that you've linked, and we've developed highly robust information systems that allow us to do this. And you can see here this is an Android phone, which is what our electronic medical record system is now being piloted to be based on. So instead of needing a computer and power and electricity, all you need is a mobile phone that has internet connectivity, and you can build a whole medical record system onto that. After that, the second biggest challenge after linkage would be retention. And this is a picture from one of our income generating programs. I'm not sure if you can see on the picture, but this girl is basically making a diabetes bracelet. And this is a project idea that started with our Street Kids Center, and now with BIGPIC, we're hoping to enroll more patients to make these bracelets, to just give them a sense of having stable income that allows them to purchase all the aspects of diabetes care that they need. Next. For those of you who are interested, I understand there is definitely some people who are interested in the audience about our mobile records technology. I don't want to spend too much time talking on that because I've already briefly mentioned it. But basically, we've developed a system that's based on the Android operating system, which means that it's open source, that allows us to use community healthcare workers that are out in rural communities to capture data that allows us to link all that patient's data into a central repository. One of the key features of this is that we can also use that data and send that data back to that community healthcare worker to provide decision support for that patient's next visit. And so this is one of the novel things that we've actually received several awards for, and Martin Webuye is one of the pioneers in this area. He received one of the top 10 mHealth Innovation Awards this year for his work on this, and it's really been revolutionizing the way we do care. Next. Now I wanted to give you some findings from AMPATH's experience in our clinics. Next. Here's just some demographic data to show you how our program works. We have a wide age range for our patients, and so from young kids to very elderly adults, they all have diabetes. You also see here that very few have outpatient health insurance. A small portion of patients smoke. A very small portion of patients even consume any alcohol, but 68% have caretaker assistance. The big things I want you to take note of here is that very few patients have outpatient health insurance. So this means the costs of care are almost totally going to fall upon cash pay for these public sector patients. And so you can imagine the cost of diabetes care if it was in a completely cash pay system. It would be very difficult for a rural resource-constrained patient to afford this. You also see that the vast majority of patients have caretaker assistance. And one of the unique aspects of care here that I really enjoy about Kenya is that the community takes a very large role in the care of every patient in their community. And so this is something that we wanted to capitalize on with the BIGPIC program. Next slide. And so now that you have all that background, all the different aspects of the determinants of health in resource-constrained settings, I wanted to explain what we're doing with BIGPIC and then also give you some of the initial data that we have from that. And so BIGPIC was basically something that I started thinking about as I was reading, Muhammad Yunus's book on microfinancing and seeing a lot of the frustrations of patients, where patients in this setting, once you empower them, they really go the extra mile and do whatever they can to make sure they get the care that they need. Whereas a lot of the times the care that we provide, many providers seem to assume that patients are incapable of very little. And I find this whole notion very objectionable. And so one day we basically discussed as a group and said, why don't we train the patients to be their own providers and also link them to stuff that gives them economic support. So if you can follow with me from the top left of this graph, the first thing that we're doing, so if you look there and then follow to the right, is identification and enrollment of rural patients with diabetes. So that's the step that we just started and are planning on ramping up next week. And so Simon, if you're in the audience, you better come ready to work because we have all the agreements in place and we're expecting you to lead a lot of this activity. So be ready. We've started identification of patients, and we're now getting into the phase where we now have meetings with the district, the Minister of Health in that area, and the department management team. And so what we're going to do next week and in the next couple months are go to these communities and start screening. And so that's step one, where you see identification and enrollment of rural patients with diabetes. Then we're going to allow patients to volunteer into this BIGPIC program. And what we're going to do in BIGPIC is give peer and self-management training. And so basically, instead of training lay community healthcare workers, we're going to train the patients themselves to provide all the aspects of care that we feel are important for them to manage their own diabetes. From there, we're going to link patients up into peer groups. And our goal is anywhere between 10 to 12 peer groups of 10 patients each. And we're going to set individual level care goals for each patient in those groups, and then also goals for the entire group. So we're going to look at how much of a reduction we can see in blood sugars and tests like the A1C, things like BMI and weight for the entire group. And we're essentially going to have these groups compete against each other. And the group that has the best outcomes out from these metrics that we've predefined will be the group that essentially can get a lot of these implements that we think are important to have them develop sustainable businesses. So things like farming tools, farming seeds, cattle, initial pilot funding for business school. We're not giving them cash. We'll give them funding for training and all these other things. And we've developed this fairly comprehensive point system where patients can decide what they want as individuals, and then also as the group will get a certain amount of points that they decide on that they'll get. One of the other things, if you look at the pyramid to the right, is that we'll do direct employment. As I mentioned, we can even hire some of these, the peer leaders of these groups to lead additional groups. We can also hire them to make some of those diabetes bracelets. One of the other things that I'll talk about in the next slide is provision of low-interest loans. And this is borrowing heavily from microfinancing concepts. The next thing you see after that is agricultural training and then also business skills training. And so this is basically how we're bringing all of these things together to do the BIGPIC model. Next slide. So you can see one of the things I mentioned is these microfinancing loans. One of our big concerns with even deploying the system was we were worried that after this initial pilot of 6 months, when we assess patients again to see how they've done and the competition is over, we were worried that the groups would just disband. And so one of the ways that we thought we could leverage microfinancing into creating this group dynamic is called a GISE, which is Group Income Savings Enterprise, where basically patients or anybody can basically form groups of 10 and everybody contributes money to this savings pool. And so let's say you have a group of 10 and all of them contribute $2 every month. At the end of the year or at the end of 6 months, the group as a team decides who gets a loan. And so then that group will disperse loans out to the individual members, and then they can do whatever they want with it. That individual then pays back the loan, and then the group will convene again and give out more loans to other members in the group. And these are self-propagating models that require very little input from and very little management from people like AMPATH or any group. All we want to do is just provide them with the initial training and let them roll with it on their own, because it, for the first time, will provide opportunities for credit to resource-constrained patients in this setting. And so that's basically how a GISE works. And so that's one of the other aspects of the BIGPIC that we're hoping to do. Next slide. And I wanted to give you some preliminary data from BIGPIC so that you can actually see that we're progressing. The biggest delay with BIGPIC was getting all the approvals we needed to actually start this thing. And as I mentioned before, that's one of the big bottlenecks in resource-constrained settings. So we finally received all the approvals, and we've now begun our program. And so the first aspect was screening. And so you can see here data on community-based screening and then also home-based screening. And I've already described these things, so I don't want to spend too much time, but I just want to go straight to the data. Next. And so you can see in this slide here, this is phase 1 for BIGPIC, where we've now done home-based screening and community-based screening. And what we found is that if you look at the HCT, which stands for Home-Based Counseling and Testing, we've screened 350 people, and we've just begun. Next week, we're planning on ramping up further, and the following week as well. We've screened 350 people via home-based screening. The number with a random blood sugar above 7 is 47, and so that's 13% of the population that have a mildly elevated random blood sugar. Now, having a mildly elevated random blood sugar is not diagnostic for diabetes. You usually need a repeat confirmatory test or an A1C or a higher level test to confirm that result. So patients typically have to come back a second time to get confirmation. And as you can see, only 40% of that 47 people return to the health center for a confirmatory test. And this goes back to that problem of linkage that I mentioned. And out of those 19, only 4 were confirmed with diabetes. And you can see here that the estimated prevalence based on this is only 1.1%. But you can readily also see how biased an estimate that is when only 40% of the patients that you think are at risk for diabetes are actually even coming in for confirmation. So we've also Can I continue? Yes. Yes. So if you, I think I got cut off right when I started talking about the community. You can see that still in that population, a very small number of patients are coming back for follow-up, and we've only been able to confirm 6 with diabetes, and largely that's because only 37% have come back for confirmation. And so our prevalence estimates for diabetes are very low, and this is largely because of the lack of follow-up. And so by doing this BIGPIC model where we're actually going to the community and basically bringing the care directly to the patient, we're hoping to address this very large issue. Next. So our next steps for this program is to continue with community-based screening, begin the training for patients within the next 2 months, obtain baseline A1Cs, and then also transition management of this project to Webuye District Hospital staff. One of the great things about working in Webuye is that the staff there are very committed. And throughout this whole program, one of the other delays is that we want to make sure that there is complete ownership of the local facility that's going to be responsible for all of these patients. And so we've worked very closely with the staff. I go to clinic there every week, and many of the residents go there pretty frequently. And Simon is actually hopefully going to live there for a month in May. I'm just not sure he knows that yet. But we're definitely planning on doing a lot more with that staff to make sure that this has ownership from the local partners. And a lot of these things may lead to long delays in the implementation of our program, but at the end of the day, I think it will create a fully robust program that can really address the needs of our patients. Next slide. If you have any questions, feel free to ask. I'd be more than happy to answer them. And if my connection goes out, I think my colleagues from Purdue and also the Kenyan pharmacy residents could also definitely answer some of the questions. This is a picture of one of our training sessions that we did a year ago that really galvanized how important this approach could be for addressing the needs of this population. Thank you.
So when you're asking your question, you can just push the button on the microphone and hold it while you ask.
Hi, this is Ann Choey. It was a great talk. I'm sure you have many, many issues that you're dealing with there all at once, trying to make this work. But I was interested in how you are coupling into the microfinance model. And specifically, I was a little bit unclear whether you're using the microfinance model to help people finance their diabetes care or as a reward for good management. I mean, what is the actual tie-in to the microfinance?
So there's, I think I heard most of your question. Basically, the question is, how are you linking microfinancing in? And I think I can just answer your question. Basically, there's two levels to BIGPIC, where the first thing is rewarding the group that does the best with their diabetes care with additional supplements. The whole microfinancing aspect is something that we're doing for every group, regardless of what happens with their outcomes. And so every group of 10 that we create, in addition to providing them with diabetes training, we're also going to use that opportunity to train them on this whole GISE model that I mentioned of microfinancing. The main reason for some of the economic stability, as you suggest, is to make sure they have enough money to continue to fund their diabetes care indefinitely. That's one aspect of it. The second big thing that I tried to kind of emphasize was that we want these groups to stay together. And through this microfinancing support group, we're hoping that we can merge care and microfinance to achieve a common goal of both helping them become economically stable on their own and also keeping the group together so that peer care can continue. And that's, I'm not sure if I answered your question completely, but the microfinance aspect we're doing regardless of how they do with their diabetes care. The incentives that we're setting up are just incentives so that the group feels the importance of improving the entire group's diabetes care. And the beauty of this is that in a Kenyan society, there is a large community sense. And so if there's one patient who's doing very poorly with their diabetes care, the whole group would realize that it's in their best interest to do whatever they can to make sure that that patient gets better. Because then as a group, their numbers would look the best as a group. It would be more important for them to assist that patient who's doing very poorly than to assist the patient who's doing very well, because you won't reduce the sugars that much more in that patient. And so it puts a little incentive to actually have the group help the patient who's doing very poorly. And so that's where the incentives come in. And microfinancing has multiple roles, but the big one for BIGPIC is that it will help keep the group together for the long run in our estimation, in our hope, and our feasibility of this.
Excuse me, can I get to the mic? Hi, can you hear me?
Yes.
This is Susan Cousins from Georgia Tech. even an Android phone actually needs some power, and it needs a mobile phone connection. So how are you, is this actually, are you working with villages that do have continuous power supplies? How are you addressing those two technological challenges to the phone-based model, which is very interesting. The whole thing is very creative.
Yeah, two levels to that question. I'll answer the easy part first. So network connectivity in Kenya, especially in our area, is nearly complete. I would say it's about 98 to 99% that have access to Safaricom. And so that's not one of the large concerns for us. In terms of having our own intranet, we actually have a group called Invinio who's coming in and installing towers throughout our catchment area so that we have intranet connectivity over that vast catchment area that I showed you in the maps. And so that internet connectivity and phone connectivity is not a big issue for us. And we've already deployed several phone-based care programs that are doing very well right now. The second part of your question was about power. So there's two layers to that. One thing is that the vast majority of patients have access to a phone or to a power source somewhere. Maybe not in their house, but if they even go to town or they go to a marketplace, you can actually even have stores that just charge your phone for you and charge you a very small price. That's one level to that question. The other thing is that we have a partnership with a company that develops solar chargers. And we have around, I think it's around 3,000 solar chargers in our warehouse that we're just waiting to use. And so we even, if patients have those issues, we can give out solar chargers. For the most part, in the phone-based care programs that we've done for patients, most patients have figured out a way to get their phones charged and keep power going. But if they're not able to, we have a solution for them as well.
Thanks.
Sonak?
Yes.
Can you hear me? This is Arden.
Very clearly.
Could you give some examples of your successes in bringing down blood sugar in the time that you've been working with these communities?
Yeah, great. So we're actually doing an analysis on the entire clinic, and we just are about to finish an analysis on a specific program we've done, which is focused on home glucose monitoring. And what we do in this program is we have a partnership with Abbott where we can give glucometers out to patients and let them borrow them. We give them enough strips to check their blood sugar twice a day, every day, and they do that at home, and we call them once a week on their cell phone. We then get all the results from this, enter them into our database, and then do insulin dosage adjustments for these patients. And what we're seeing on average from our most recent analysis is that most patients experience anywhere between a 25 to 30% drop in their hemoglobin A1C. And I'm not sure who's in the audience there, but this is a huge reduction in the causes of mortality for diabetes. So with each point reduction in A1C, you typically see a reduction in mortality of 21%, a reduction in microvascular complications like retinopathy by around 27 to 30%, and cardiac complications go down by about 30% as well. And so with each 1 point drop in A1C, that's how much you see. And what we're seeing through this phone-based care model is a 4-point drop in their hemoglobin A1C, just to give you some context. And there's a slide that's hidden in this presentation later on in case you wanted to see any of that data. But we now have 260 patients enrolled in that, and the data analysis that we're about to present and publish is for 240 patients, and that's the data that we're seeing. And another comment just to show kind of the benefit of this GPRI funding, that data that I showed you on this community-based screening versus the home-based screening will actually be published in a manuscript within 6 months. There's actually a journal that's actually requested that data from us because they attended one of the presentations we gave and wanted that data. And so that's another indirect benefit of this GPRI funding, is that we'll definitely have 2 or 3 different publications and enough pilot data to fund additional grants and request additional grants in the future.
Thank you very much, Sonak, for your presentation. I would say that this turned out to be a very impressive presentation by Skype for over such a long distance, and we're very grateful that you took time in your afternoon to talk with us. And good luck to you.
It's testament to the fact that internet has improved in Kenya.
Yeah. Yeah, our best wishes for you and your continued work.
One more comment. If you want to see the data on home glucose monitoring, I have it in, if Ellen can go to the hidden slides, it's slide 44 in the hidden slides. And I also encourage any of you to talk to the residents who are there and the people who've been in the program for some years. And that's Ellen Shellhouse and Monica Miller. Please ask them more questions because they're very aware of our work.
Sonak, you know what I'm going to say next. I want all your slides for our website. So we'll post them on the website along with your presentation.